Good morning, everybody. Our lecture today is odontogenic infections, especially facial space infections. It is a continue to our previous lecture, which was an introduction to the odontogenic infections. Now we will enter in details with the types of odontogenic infections. Facial space infection. What are the facial spaces? They are fascia-lined tissue compartments filled with loose areolar connective tissue. They serve to cushion muscles, vessels, nerves, glands, and other structures that it surrounds and allow relative movement between these structures. Normally, in the body, there is no space, but during infection, these potential spaces have the ability to become inflamed when invaded by microorganisms. So they create a space created by the liquefaction necrosis, which is the abscess. When we see in the X-ray, we have radiolucent area surrounding, such as surrounding the apex of a central, we see a radiolucent area. It is a void. Normally a void. It's called a space. Normally in the body there is not such thing as a space. So the facial spaces have the ability to become inflamed. When inflamed, they become indurated, and then, as I said, with the liquefaction necrosis, it will lead to abscess formation. These abscesses will resolve once it is drained, either surgically or spontaneously. Based on the relationship between the point at which the infection erodes through the alveolar bone and surrounding muscle attachment, infection arises from either maxillary or mandibular teeth. Either from maxillary or from mandibular. Primary spaces, they are spaces that involved directly by the infection from the oral cavity, like infection spread from maxillary molar to the buccal space. This is direct route from the maxillary molar to the buccal root, or infection spread from the mandibular third molar to the submandibular space. This is also a direct route. So, what are the types of primary spaces that we have? Either primary maxillary or primary mandibular spaces. Primary maxillary spaces, they are labial, vestibular, infraorbital, buccal, and infratemporal. While the mandibular, the buccal, also perimandibular spaces, which consist of submandibular, sublingual, submental, sublingual, submandibular. The other type of spaces, which are the secondary spaces. Secondary spaces, the spread of infection from primary spaces will reach to secondary spaces, will lead to the involvement of the secondary spaces. So they are not directly, so the spread of infection is not directly from the oral cavity. It will come from the primary spaces. Also, we have secondary maxillary spaces like periorbital and orbital spaces, and cavernous sinus also. Secondary mandibular, like the masticator spaces, deep cervical fascia spaces. We will discuss each of these spaces in details, but the important point we need to learn here is that the primary spaces, the infection came directly from the oral cavity. The secondary spaces, the spread of infection came from the primary space. First, we have the primary maxillary spaces. What we have the first space, which is the labial vestibular space. Its location it's located between the vestibular mucosa and the muscles of facial expression. Between the vestibular mucosa and the muscles of facial expression. From where the infection come to this space, it comes to this space from maxillary, central, and sometimes from maxillary canine. Usually the roots will become in close approximation with the buccal cortex of the bone. Their roots are close to the buccal side down to the palatal side, so the infection spread will lead to involvement of the labial vestibular space. Its connection this space is connected with the canine and with the buccal space. What are the signs and symptoms? What do I see when the patient come suffering from labial vestibular space? From vestibular, a fluctuation and swelling. As we see here, we see a swelling of the upper lip. When I examine the area intraorally, I'll see vestibular swelling and fluctuation. Fluctuation mean when I physically examine the swelling, I feel liquid under my arms, under my fingers. This is the labial vestibular space infection. What is the surgical approach to this? To the drainage of this space is vestibular incision. We will see in this lecture with every space I put a line the surgical approach, because one of the most important lines of the treatment in odontogenic infection is incision and drainage. The surgical approach, it is even more important than the antibiotic therapy. So with each space we will discuss the surgical approach to it, and the details of the surgical approach we will discuss it later in the next lecture, God willing. As I said, the vestibular incision we will done on the top of the swelling and the maximum point of the swelling with the insertion of the drain. This is the surgical approach, the vestibular incision. So whenever I say vestibular incision in this lecture, this is how we done it. Maximum swelling, incision, I made an incision and insertion of the drain, and making a stitch of the drain with the soft tissue so that it would not be lost, and we ensure perfect drainage of the abscess. Another primary maxillary space is infraorbital, or sometimes we call it a canine space infection. Its location, it's between levator angulioris, this is levator angulioris, and between levator labii superioris. So this area here will be the area of canine space infection. The cause of infection, as I say, from its name, canine space, so the cause is from maxillary canine. The canine root often is sufficiently long to allow erosion occur, superior to the origin of levator angulioris and below the origin of levator labii superioris. What are the content of this space? This space contains angular artery and vein and infraorbital nerve. So as we progress in the spaces, we will see vital structures involved. These vital structures may tend to become injured if I don't care during incision and the drainage. So I must know the correct position or the correct location of the space and what its content. So when I do incision and the drainage, know where and how and when to make the incision without causing any permanent damage. Its connection, it is connected to the vestibular space and to the buccal space. What are the signs and symptoms of this space? How it will present itself to me? I will see the patient, as we see this patient, edema spread toward the medial canthus of the eye. Here it's the canine space, it's spread to the medial canthus of the eye, and the lower eyelid also involved, and the side of the nose, as far as to the corner of the mouth, sometimes even to the corner of the mouth. This is the area of involvement of canine space infection. I see swelling and edema and redness all over this area. There is also obliteration of the nasolabial fold. Here I can't see the nasolabial fold due to the swelling. Also, I see obliteration if I open the patient mouth of the mucobuccal fold, because the swelling also presents itself extraorally and intraorally. Spontaneous drainage of this infection commonly occur near the medial or lateral canthus of the eye. This is area of soft tissue, thin tissue that the infection can erode. So either through the medial or lateral canthus of the eye. As I said, because it is have thin tissue and least resistant tissue. What is the surgical approach? Also, vestibular incision. As I say, I will make an incision intraorally inside the mouth, incision here, and insertion of the drain and fastening the drain with a suture. This is the vestibular incision. This is the vestibular incision. Buccal space infection. As I mentioned before, buccal space can be involved either from maxillary teeth or mandibular teeth. So during examination, when the patient presents himself to our clinic with buccal space infection, I examine the oral cavity well to see which tooth caused this infection. It is a maxillary tooth or mandibular tooth. In the lecture, you will see that the buccal space is the same description in the maxillary spaces and in mandibular spaces, as we will discuss in here. What its location or boundaries, the boundaries of buccal space. It's bounded by the overlying skin of the face on the lateral aspect and the buccinator muscle on the medial aspect. So medially we have the buccinator muscle, laterally we have the overlying skin. The zygomatic arch from the superior aspect of this space and the lower border of the mandible from the inferior aspect. So medially buccinator, laterally the skin, superiorly zygomatic arch, inferiorly the lower border of the mandible. What are the content of buccal space? It contains parotid duct, anterior fascial artery and vein, transverse fascial artery and vein, and buccal fat pad. As I said, the etiology or the spread of infection of this space will come either from the maxillary teeth when the infection erode above the attachment of the vaccinator, or from the mandibular teeth when the infection erode below the attachment of the vaccinator. Posterior maxillary teeth, most commonly molars and rarely premolars, can cause most buccal space infection. Its connections with other spaces, it connects with the vestibular space, infraorbital space, periorbital space, superficial temporal, and infratemporal perimandibular spaces. Why these connections are important? As I said, the secondary spaces will be involved from primary spaces. So when I know this secondary space or this primary space where it will lead, I can know the complications or the outcome if there are no treatment. What are the signs and symptoms? The patient presents with a swelling. The swelling is confined between the area below the zygomatic arch and above the inferior border of the mandible. This is the buccal space infection, or this is the swelling of buccal space infection. What is the surgical approach? The surgical approach to buccal space infection, it's either intraoral or extraoral approach. Intraoral through vestibular incision. Why? For three main reasons I choose this intraoral approach. The abscess fluctuates intraorally in the majority of cases. Secondly, avoid injury to the fascial nerve. And third, for aesthetic reasons, of course, I can't put an incision in the cheek of the patient. So, this is the area of vestibular incision for buccal space involvement. This is the area. The extraoral incision in some cases I will use extraoral incision or submandibular incision. Submandibular incision we will see it, we will use it in another types of facial spaces involvement. So this is its discussion. This is the lower edge of the mandible, about 1 to 2 centimeters below the lower ledge of the mandible. I will do the incision parallel to the lower edge of the mandible, parallel to the lower edge of the mandible. Why I use this extraoral incision? As I said, it's not aesthetically acceptable, but when the intraoral incision is not enough, if we have a large space involvement, a large infection, I will need to another site of secondary incision, another site, secondary incision and drainage for the abscess. And when the pus is deep inside the space, I cannot reach it through the vestibular incision. The final primary maxillary space is the infratemporal space. This is the infratemporal space. It is located behind the maxilla or posterior to the maxilla. So when I ask what is the anterior boundary of the infratemporal space, it will be the maxilla. It's medially bounded by the lateral pterygoid plate of the sphenoid bone. Laterally, it is continuous with the deep temporal space. It contains branches of the internal maxillary artery and the pterygoid venous plexus. Due to the presence of the pterygoid venous plexus, any infection in this space must be dealt with a high priority. Any infection in the infratemporal space may erode to the pterygoid venous plexus and will reach the cavernous sinus through the emissary veins, leading to a life-threatening situation, which is a cavernous sinus thrombosis. We will discuss cavernous sinus thrombosis in a few slides later. Connections of this space is with the deep temporal. As I said, it is continuous with the deep temporal, pterygomandibular, buccal, and orbital spaces. What are the signs and symptoms of infratemporal space involvement? It is trismus, mainly trismus, and pain during mouth opening and with lateral deviation to the affected side, edema in the area anterior to the ear, extend above the zygomatic arch, and as well edema of the lower eyelid. Why there is a trismus and pain? Because this space have the involvement of masticatory muscles. When this space involved, when any space involved where these masticatory muscles are present, the surgical approach for a drainage for the infratemporal space is either through intraoral vestibular incision, which occur almost at the area above the third molar, and also through an extraoral incision. This is the extraoral incision for the drainage of the infratemporal space. It is performed in the skin in a superior direction, which means I start from below and go above. This is called in a superior direction. It extends approximately 3 centimeters. It will start from the junction of the frontal and temporal processes of the zygomatic bone and extend superiorly. Now we will discuss secondary maxillary spaces. First of all, we have periorbital or orbital cellulitis. What is the difference between periorbital and orbital cellulitis? There is an orbital septum that separates the extraoral from the intraoral content of the oral cavity. If the infection occur in front of the orbital septum, it will be called periorbital cellulitis. If the infection occur behind the orbital septum, it will be called orbital cellulitis. In both of these infections, we will see swelling and redness of the eye and the eyelid. Also, we will see fever and pain. But how can I differentiate the periorbital from the orbital? In the periorbital cellulitis, there is no pain in the eye movement because the muscles that involved in the movement of the eye are not affected. So there is no pain with the movement of the eye and the vision is normal. While in the orbital cellulitis, I will see a pain during the movement of the eye, double vision or blurry vision, and proptosis or bulging of the eye, as I see in this picture. Maxillary secondary space involvement is cavernous sinus thrombosis. It is a life-threatening serious infection, require aggressive medical and surgical care, and has a high mortality rate even today. This is cavernous sinus. It is situated inside the brain. It has veins drains to it from all over the face and the brain. Cavernous sinus thrombosis is an intravascular inflammation caused by invading bacteria that stimulates the clotting pathway, which lead to the formation of a thrombus in the cavernous sinus and its communicating branches. It is rarely occur due to an infected tooth. But as infected tooth is one of its causes, so we should know this this involvement, this space involvement. The spread of infection usually due to anterior route or posterior route. Because the veins of the face and the orbit have no valves, so blood-borne infection in this area, an infection in this area will erode through these veins and reach to the cavernous sinus. The anterior route, infection erode through the superior ophthalmic through the angular vein or the inferior ophthalmic vein, and which passes through the superior ophthalmic, which passes through the superior orbital fascial and extend to the cavernous sinus. So either from the superior ophthalmic or inferior ophthalmic vein. This is the anterior route. The posterior route from the emissary veins. The emissary veins from the pterygoid venous plexus. As we said, pterygoid venous plexus is situated in the infratemporal space. So if we not deal with any infection or involvement of infratemporal space, the infection will erode to the pterygoid venous plexus and will travel through the emissary veins to the cavernous sinus, leading to cavernous sinus thrombosis. What are the content of cavernous sinus? What is the reason that make cavernous sinus thrombosis is so dangerous? It contains the cranial nerves, oculomotor, trochlear, the ophthalmic maxillary branch of the trigeminal nerve, and epideucens, which accompanied by the horizontal segment of the internal carotid artery. So we have four important cranial nerves entering through the cavernous sinus with the internal carotid artery. So any infection, any thrombosis in this area will be very dangerous. The sign and symptoms, mainly we will see an eye involvement. It include periorbital swelling. It include periorbital swelling and redness. As we see here, periorbital swelling and redness. Also, we will see ptosis, which is a dropping of the upper eyelid. Proptosis, which is bulging of the eye. Chemosis, which is edema of the conjunctiva and the swelling around the cornea. Ophthalmoplasia, external ophthalmoplasia, which is paralysis of one or more of the muscles of the eye. Decreased visual acuity, the patient will not see clearly. These eye symptoms, which will start in one eye and then spread to the other eye within the 24 to 48 hours. Other symptoms may include fever, headache, seizures. One of its complication is meningitis and also sepsis. So as I say, this is a dangerous infection. If any patient present to your clinic with these signs and symptoms, you should immediately hospitalize the patient under a super and refer him to a maxillofacial specialist. Now we will start discussing the mandibular spaces. First of all, we have the buccal space. As I said before, the buccal space description is the same in the maxillary and mandibular spaces. The only difference will be in the causative factor. But I will repeat the description again. Its boundaries between the overlying skin and the buccinator muscle. Overlying skin laterally and the buccinator muscle medially. its superior aspect lined by the zygomatic bone, the zygomatic arch, sorry, and inferiorly by the lower border of the mandible. Its content is the parotid duct, anterior facial artery and vein, transverse facial artery and vein, and buccal fat pad. The etiology, which is the difference between the infection of buccal space in mandibular and maxillary spaces, is from mandibular teeth. As I said, when patient present himself to our clinic with a buccal space infection, the intraoral examination concentrate to locate the causative tooth. It is either maxillary tooth or mandibular tooth. So, the most common teeth that cause buccal space infection is the mandibular posterior teeth, especially the molars, when they perforate the bone and the periosteum below the attachment. This is the attachment here. This is the attachment of buccinator muscle. When the infection perforates the bone below the attachment of buccinator muscle, it will enter between the buccinator. The infection or the pus will accumulate between the buccinator and the overlying muscle, causing a buccal space involvement. Its connections, as I said before, with the vestibular space and infraorbital space, periorbital, superficial temporal, and infratemporal pterygomandibular spaces. The signs and symptoms, the same as in the maxillary caused buccal space infection. From we will see swelling from the zygomatic arch to the inferior border of the mandible. As I see here, this is the zygomatic arch. This is swelling from the zygomatic arch to the inferior border of the mandible. The surgical approach, either intraoral, here the incision will be either intraoral or extraoral, as we discussed it. Second, we have the perimandibular spaces. These are a collection of spaces that are connected with each other and connected through left and right. There is no separation between them. The first of the perimandibular spaces, we have the submental space. This is the submental space, the yellow color. This is the submental space. What are the boundaries of the submental space? Laterally and on both sides, we have the anterior belly of digastric. This is the anterior belly of the digastric. Laterally on both sides. As I said, these spaces are connected. Connected, which means the right and left side are connected. There is no distinction line. This is the line, the midline, but we see here it is a perfect triangle. The submental space. It is lined by the anterior belly of digastric. The mylohyoid superiorly, which means it's covered by the mylohyoid. This is the mylohyoid muscle. It's covered by the mylohyoid muscle. This is the mylohyoid. And the overlying fascia inferiorly, which means this space is between the fascia and the mylohyoid muscle. The content of this space is anterior jugular vein and submental lymph nodes. The etiology, the cause or the spread of infection from where? Isolated submental space infection are rare. As I said, they are connected. The perimandibular space are connected, so isolated submental is rare. It's usually caused by infection from central incisors, from mandibular incisors, central or lateral mandibular incisors. Also, spread of infection from the submandibular space cause the involvement of the submental space. Um, its connection, as we said now, with the submandibular space. The sign and symptoms. How the patient will come to the clinic, and I know this is a submental space. The patient will present himself with indurated and painful submental edema. This is as we see here a slight redness of the skin with swelling. It would be indurated and painful, and later will be fluctuant, which means there is a pus in the area. The surgical approach to submental space is through extraoral incision. Incision in the skin. Incision is made in the skin beneath the chin. This is the border of the chin. This is the border, as we see here. This is the inferior border of the mandible, inferior border of the chin. Below it, in a horizontal direction, parallel للanterior border of the parallel anterior border of the chin. This is the submental incision for drainage of submental space. Another perimandibular space is the sublingual space. The sublingual space, its boundaries, it is located. This is the sublingual space, colored green, and this is the submandibular space, colored yellow. The sublingual space is located between the mucous membrane or the oral mucosa of the floor of the mouth and the mylohyoid muscle, between the oral mucosa and the mylohyoid muscle. Anteriorly and laterally, it is bounded by the inner surface of the body of the mandible, and medially by the genioglossus and geniohyoid muscles, the muscles of tongue. The posterior border of the sublingual space is open, so it is freely communicates with the submandibular space. Its content is the submandibular duct, the sublingual salivary gland, the lingual nerve and lingual vein, and part of the submandibular salivary gland. The etiology, as we said in the previous lecture, the factor that determine the infection goes to sublingual or submandibular space infection is the attachment of mylohyoid muscle. If the infection, this is the green line, if the infection erode above the attachment of the mylohyoid muscle, it will lead to a sublingual space infection. The most common teeth involved in sublingual space involvement are the premolars and the first molar. If the erosion of the infection occur below the mylohyoid muscle, it will lead to a submandibular space involvement. The most common tooth associated with submandibular space involvement is the lower third molar. The lower second molar have a 50-50 chance of causing a sublingual or submandibular, depending on the position of the root and the site of erosion of infection. Connections, as we said, it freely communicate with the submandibular and from there to the lateral pharyngeal space. Sign and symptoms. How I see the patient, how I determine this patient have a sublingual space infection. Swelling of the mucosa of the floor of the mouth resulting in elevation of the tongue. This is swelling, as we see here, swelling of the oral mucosa in the floor of the mouth, leading to elevation of the tongue toward the palate. we will see little or no extraoral swelling. The mandibular lingual sulcus is obliterated, as we see, due to the swelling, and the mucosa presents with a bluish tint, a bluish color. The patient speaks with difficulty because the swelling is lifting the tongue, and the movement of the tongue are painful. 2. Sublingual space is through the intraoral incision. The incision is made laterally and parallel to the Wharton's duct, which lines in here. So this is the incision line, as we see here. The pus, this is the pus coming out from the sublingual space infection. After the incision, we insert a hemostat to open the incision and let all the pus out. If this intraoral approach doesn't cause sufficient drainage, we will have to do a submandibular incision, extraoral submandibular incision. As we said before, it will be 1 to 2 centimeters below the lower border of the mandible. The third and final perimandibular space is the submandibular space. The location of submandibular space, or the boundaries, it lies between the mylohyoid muscle superiorly and the overlying superficial layer of deep cervical fascia inferiorly. So it lies between the mylohyoid muscle and between the superficial fascia, the superficial layer of deep cervical fascia. It's bounded laterally by the inferior border of the mandible, medially by the anterior belly of the digastric, here medially by the anterior belly of the digastric, posteriorly by the stylohyoid ligament and the posterior belly of the digastric. The posterior extent of submandibular space communicates with the deep fascial spaces of the neck that we will discuss later. The content of submandibular space is fascial artery and vein, and the submandibular salivary gland, and submandibular lymph node. The etiology, as we said, if the infection erode below the attachment of mylohyoid muscle, it will cause a submandibular space infection. The most common tooth involved is the mandibular third molar, or and sometimes the second molar, if it lies beneath, if the apex of the root lies beneath the attachment of the mylohyoid. It may also occur, the infection of submandibular space also occur as a spread of infection from sublingual or submental spaces. As we said, these three spaces, the premandibular spaces, are freely communicate with each other. So infection from submental will lead to infection in sublingual or submandibular, and the opposite also, from submandibular to sublingual and submental. The patient, what are the signs and symptoms? Moderate swelling at the submandibular area. This is the submandibular area. The mandible, the submandibular area. Moderate swelling at the submandibular area, which spreads, creating greater edema indurated with redness of the overlying skin. In addition, the angle of the is obliterated due to the swelling. And the patient will feel pain during palpation. When we examine the patient, he will feel pain, and we will see moderated erythemas due to the involvement of medial pterygoid muscle. The surgical approach It is through extraoral surgical approach, through the submandibular incision, we will made here, as we said, it will be 1 to 2 centimeters parallel and below the inferior border of the mandible. This is the submandibular incision. Almost below the angle of the mandible. What is Ludwig's angina? Ludwig's angina, it is a complication of involvement of perimandibular space. When the perimandibular spaces, the submandibular, sublingual, and submental, are bilaterally involved in an infection, it is called Ludwig's angina. So it is the involvement of the three perimandibular spaces on the both sides, left and right sides. The most common cause of Ludwig angina is an odontogenic infection, of course. The infection is rapidly spreading cellulitis that can obstruct the airway and commonly spread posteriorly to the deep fascial spaces of the neck. Severe swelling is almost always seen, as we see here. Severe swelling with elevation and displacement of the tongue. This elevation is due to the swelling. The patient is unable to close his mouth. Tense and tender bilateral induration of the submandibular region. When I palpate it, it will be tense and tender. For the patient usually has trismus, drooling, as we said, because he cannot close his mouth. He cannot. He doesn't have the ability to close his mouth. Difficulty in swallowing, and sometimes breathing. As we said, this swallowing may affect the airways, obstruct the airways. The patient often experiences severe anxiety over the inability of swallowing and maintain the airway. This infection proceeds with an alarming speed, and this may produce upper airway obstruction that often leads to death. The management of Ludwig's angina is initially, and the most important thing is securing the airway. I make sure that the patient can breathe, and then perform early and aggressive incision and drainage with antibiotic therapy. But here the antibiotic therapy have only supportive role. The main treatment line in Ludwig's angina or any space involvement is incision and drainage. The drainage of the pus. It is the most important line in the management of any severe infection, of any infection at all. This is the incision. We will have at least two sides, the submandibular and submental incision, at least two sides, and from both sides, two sides, submandibular and submental, and both sides. This is will occur in the midline and submandibular from the right and left side to ensure a complete drainage and aggressive drainage of the pus in case of Ludwig's angina. After we finished the primary spaces in the mandible or the mandibulary primary spaces, we will now discuss the secondary mandibular spaces. The first one is the masticator space. Why it is masticator space? Because why we call it masticator spaces? Because it is formed by splitting of the superficial layer of deep cervical fascia surrounding the muscles of mastications. All these spaces are around the muscles of mastications. So any involvement of the any one of these masticator spaces will cause trismus because they are involved with the masticators, with the muscles of mastications. Within this space, we have 4 compartments or 4 spaces. They usually behave separately, but in severe and long-standing infections, we may present with the involvement of all these 4 compartments. The masticator spaces are the submasseteric space, pterygomandibular space, the deep temporal and superficial temporal. So the masseteric space, submasseteric space in this blue color, the pterygomandibular space in this brown color, deep cervical in the red color, and deep temporal in red color, and superficial temporal in green color. The first of the masticator space, which is one of the secondary mandibular spaces, is the submasseteric space. Its location, it is located between the masseter muscle, laterally, and the lateral surface of the ascending ramus of the mandible medially. So it is between the masseteric muscle and the ascending ramus of the mandible. The zygomatic arch will lie superiorly, and the lower border of the mandible inferiorly. Its content is masseteric artery and vein. The etiology of infection or spread of infection. Infection most commonly as a result of spread of infection from buccal space. As we said, secondary spaces does not usually the infection does not come usually directly from the oral cavity, but from other spaces. So in the case of submasseteric space, the infection usually comes from the buccal space or from soft tissue infection around the third molar, pericoronitis. Occasionally, an infected mandibular angle fracture also causes submasseteric space infection. The connections of this space is with the buccal, parotid, and the rest of the masticator spaces. Signs and symptoms. How will the patient present? The masseter muscle will become inflamed and swollen. The patient will have moderate to severe trismus, inability to open the mouth, due to the involvement of the masseter muscle. This is the swelling that the patient comes. As we see here, I cannot differentiate this from buccal space infection. The deciding factor is the trismus. If the patient comes with infection of the side of the mouth with trismus, it will be a submasseteric space. Without the trismus, it will be a buccal space infection. The surgical approach is through intraoral incision. It will occur here. It's the same site as the buccal. This is the site of the submasseteric space incision. The incision begins at the coronoid process and run at the coronoid. The incision begins at the coronoid process and run along the anterior border of the ramus toward the mucobuccal fold as far as to the second molar, or sometimes even to the first molar. The other and one of the most important secondary spaces is the pterygomandibular space. Why this space is important? Because it is the space into which the local anesthesia is injected during inferior alveolar nerve block. It is located between the medial pterygoid muscle, located between the medial pterygoid muscle medially and the medial surface of the ascending ramus laterally. This is the pterygomandibular space. Its content is the mandibular division of trigeminal nerve, inferior alveolar artery, and vein. The etiology is usually involvement from mandibular third molar, and also an infection from needle tract during injection of the inferior alveolar nerve block. Its connection is with the buccal space, lateral pharyngeal space, submesenteric deep temporal spaces, parotid and peritonsillar spaces. The signs and symptoms. The patient will present with little or no facial swelling. I will see no extraoral swelling. However, the patient is almost always has a significant trismus. Therefore, trismus without any swelling is a valuable diagnostic tool to differentiate the pterygomandibular space infection. The surgical approach is through either intraoral approach, a vertical incision, lateral and parallel to the raphe. This is the pterygomandibular raphe, so I will do an incision lateral and parallel to the pterygomandibular raphe. If this is not sufficient, I will do an extraoral submandibular approach at the angle of the mandible. The other submesenteric space is the superficial and deep temporal spaces. The location of the superficial temporal or its boundaries, it is bounded laterally by the temporal fascia and medially by the temporalis muscle. So it is bounded by between the temporal fascia and the temporalis muscle. Its content is the temporal fat pad, temporal branch of the fascial nerve. It rarely becomes infected and usually only in severe infection due to spread of infection from infratemporal space with its communicates. Connection with buccal and deep temporal spaces. Signs and symptoms, we will see swelling over the temporal region, superior to the zygomatic arch and posterior to the lateral orbital rim, behind the eye, swelling on the side on the temporal region behind the eye above the zygomatic arch. The deep temporal space is located between the medial surface of the temporalis muscle and the temporal bone, between the temporal bone and the medial surface of the temporalis muscle. It contains the mandibular division of trigeminal nerve and skull base foramina. Etiology, it rarely becomes infected, usually in severe infection. Its connection is with the infratemporal space, superficial temporal space, and the inferior petrosal sinus. Sinus symptoms, as with the superficial temporal, also swelling over the temporal region, superior to the zygomatic arch behind the orbit. The surgical approach to the superficial and deep temporal is through extraoral incision. This is the incision for drainage for superficial and deep temporal. The incision is made horizontally at the margin. This is the margin parallel to the margin of the skull pair, approximately 3 centimeters above the zygomatic arch. This is the zygomatic arch, 3 centimeters above, horizontal and parallel to the hairline. We will do the incision for drainage of superficial and deep temporal. The other secondary mandibular spaces are the deep cervical fascial spaces. Extension of odontogenic infection beyond the spaces we described earlier is uncommon. However, when it does happen, involvement of deep cervical spaces may have a serious life-threatening complications. Infection of deep fascial spaces of the neck can cause compression, deviation, or complete obstruction of the airway, invading vital structures such as major vessels, and allow the extension of infection into the mediastinum and its vital structures. The first of the deep cervical fascial spaces is the lateral pharyngeal space. It is described as a pyramid, so we will discuss its borders as a pyramid. It extends from the base of the skull superiorly to the hyoid bone inferiorly. Its medial border is the medial pterygoid muscle and the ramus of the mandible, and medially, this is the medially, by the superior constrictor muscle, bounded anteriorly by the pterygomandibular raphe, and extend posteriorly to the prevertebral fascia. Its content is the styloid process and the associated muscles and fascia. The styloid process and the associated muscles and fascia divide the lateral pharyngeal space into an anterior compartment which contain primarily loose connective tissue and posterior compartment which contain the carotid sheath, cranial nerves, the glossopharyngeal, the vagus, and the hypoglossal. The etiology or the spread of infection to this space is usually from lower third molar, from the tonsils, or infection from the neighboring spaces. Its connections is with the pterygomandibular, with this, as we see here, it's connect with the pterygomandibular, with the submandibular, with the sublingual, and peritonsillar and retropharyngeal. The sign and symptoms. How will patient present? Trismus, usually, as a result of inflammation of medial pterygoid. As we say, any space have its in its boundaries any of the masticator muscles, we will see trismus. The patient will complain of a trismus. Lateral swelling of the neck, especially between the angle of the mandible and the sternocleidomastoid muscle. This is the area of swelling. Swelling of the lateral pharyngeal wall causing its bulging and fever. Here we see the swelling of the lateral pharyngeal wall. This is swelling of the lateral pharyngeal wall. The complications of lateral pharyngeal space when it is involved, the odontogenic infection is severe. يعني لما الانفكشن توصل lateral pharyngeal معناها الانفكشن اللي عندي severe and may progress at a rapid rate. It has a direct effect on the content of the space. هسه حكينا احنا شنو هي الكونتنت مالته، كلها nerves والكاروتيد sheath، خاصة اللي بالposterior compartment. شنو what are these complications? The complications include thrombus in the internal jugular vein, erosion of the carotid artery or its branches, interference with the cranial nerves, the glossopharyngeal vagus, and hypoglossal. Other serious complications may arise if the infection progresses from the lateral pharyngeal to the retropharyngeal and beyond. The surgical approach is either through extraoral approach, a submandibular incision also at the angle of the mandible, or an intraoral approach, an incision in the lateral pharyngeal wall. This is the site of incision. Incision at the lateral pharyngeal wall. The other deep cervical fascial space is the retropharyngeal space. It lies behind the soft tissue of the posterior aspect of the pharynx. This is the yellow color, is the retropharyngeal space, lie behind the soft tissue of the posterior aspect of the pharynx. It is bounded anteriorly by the pharyngeal constrictor muscle and the retropharyngeal fascia. Posteriorly, it lies by the alar portion of the deep cervical fascia. This is the posterior boundary, alar border of the deep layer of deep cervical fascia. It extends from the base of the skull and ends inferiorly by the fusion of the alar and prevertebral fascia between the sixth cervical and the fourth thoracic. This is almost the area. May extend from the sixth to the fourth thoracic. It contains loose connective tissue and lymph node. Etiology: spread of infection from lateral pharyngeal. Retropharyngeal will have an infection when the lateral pharyngeal space is involved. Signs and symptoms: the same symptoms as we discussed in the lateral pharyngeal we will see in the retropharyngeal, but with greater difficulty in swallowing due to edema of the posterior wall of the pharynx. The posterior wall of the pharynx will be edematous, there will be difficulty in swallowing, as well as the other signs we discussed in the lateral pharyngeal, which is a trismus, lateral swelling of the neck, and the swelling of the lateral pharyngeal wall. Complications: it will cause obstruction of the upper respiratory tract due to displacement of the posterior wall of the pharynx anteriorly. Rupture of the abscess and aspiration of the pus into the lung will cause asphyxiation and spread of infection to the mediastinum. The surgical approach is drainage through the lateral pharyngeal space. The other space we have is the parotid space. And we have other one is the prevertebral space. The parotid and the prevertebral are just for information للإطلاع فقط، لأنه الموضوع كلش ضخم وصعب فما أريد أطولها عليكم، فهذه البارotid والبريفرتبرال وراها راح تكون للإطلاع فقط، لازم تعرفوها بس ما مطالبين بيها بالامتحان. The parotid space, it is located between the superficial layer of deep cervical fascia it's located between the superficial layer of deep cervical fascia. The space extends from the external auditory meatus to the angle of the mandible. It is located lateral to the carotid and pharyngeal spaces and posterior to the masticator space. So it lies behind the masticator spaces. It contains the parotid gland and its duct, the external carotid artery, superficial temporal and fascial artery, retromandibular vein, the auriculotemporal nerve, and fascial nerve. Etiology: the infection will spread from lateral pharyngeal, will lead to involvement of parotid or parotitis, infection of the parotid, or cellulitis. Any problem in the parotid will cause involvement of the parotid space. Signs and symptoms: we will see an edema of the retromandibular and parotid region, trismus and difficulty in swallowing, pain during chewing, which radiates to the ear and temporal region. In certain cases, we will see redness of the skin and subcutaneous fluctuation. Also, a purulent exudate may be seen coming from the parotid duct when a pressure is applied. The surgical approach is through extraoral approach, a broad incision posterior to the angle of the mandible. The other deep cervical fascia space is the prevertebral space. This red color is the prevertebral space. It is rarely involved due to an odontogenic infection because the prevertebral fascia is firmly adhered to the vertebral bodies. It is located. This potential space is extended from the base of the skull to the coccyx. It is located anterior to the vertebral body. These are the vertebral bodies. It's located anterior to the vertebral bodies and behind the prevertebral fascia. Laterally, it is limited by the fusion of the prevertebral fascia with the transverse process of the vertebral bodies. The spread of infection to this prevertebral space may due to osteomyelitis of the vertebrae, trauma, or may originate from cervical or thoracic spine injuries. Signs and symptoms. Diagnosis is difficult to make. The patient may present with neck and or back pain, fever, neurologic dysfunction ranging from nerve root pain to paralysis. MRI is the choice for diagnosing this prevertebral involvement. We will see epidural or spinal cord involvement. Thank you.